many of them. It's futile to name them. You know, how are you going to go? Large bronchiole, middle bronchiole, smaller bronchiole. No. So we're going to go from bronchi designated by cartilage to bronchioles, no cartilage. What we do know is that the bronchioles that are respiratory bronchioles are called terminals, and these lead to the respiratory bronchioles, which lead to alveolar ducts, which lead to sacs of alveoli. We know that there's a transition of epithelium from pseudostratified ciliated columnar in the trachea and the large bronchi to low columnar. You might have some ciliated columnar. You might have some that are not ciliated in the terminal bronchioles. Those bronchioles are going to transition from pseudostratified to columnar ciliated to columnar, and then from columnar we transition to cuboidal in the respiratory bronchioles, and from the cuboidal epithelium we transition to squamous cells. We know that we have a good blood supply surrounding all of our alveolar sacs. We know that we have differences in the number of ducts, right, on each of these bronchioles, and the respiratory bronchioles are called part of the respiratory zone because they have the alveoli bouncing off of them. Yep. We know, remember about the circulatory system, how important it is that you remember pulmonary venules versus pulmonary arterioles. Which ones are bringing blood to the heart from the alveoli? Venules. And what kind of blood are they carrying?
Oxygen.
Freshly oxygenated blood, right? It's one of those Bass acrid, as my trigonometry teacher used to say. Bass acrid, yep. We looked at the alveoli. We started to look at this, right? We know that we have our type 1 alveolar cells are squamous cells. We have these type 2 alveolar cells called our type 2. And what do these guys do? These are very important. They produce surfactant. Why is surfactant a valuable fluid?
Keep the sacs from sticking together.
And?
Antibacterial?
No. Keeps them from collapsing and sticking to each other. Surface tension. Well, what does surface tension have to do with anything? Who cares about surface tension?
Moves more easily without it, right?
Gases move more easily with it.
Okay.
Right? Surface tension, without it. Sorry.
I was like,
Getting rid of the surface tension via surfactant means that we have easier diffusion of gases between the air in the alveoli and the blood.
Without the surface.
The surfactant eliminates surface tension.
So without it, it can move easier because the tension would stop it.
The surface tension prevents easy flow.
Yeah.
So surfactant eliminates the surface tension.
Yeah.
Yes.
Which eliminates diffusion.
Which enables
makes it harder.
Surface tension makes diffusion harder.
Okay.
Without it, easier diffusion.
Okay.
Yeah.
I was confused about it.
So we got the type 1s, we got the type 2s, and we also have these guys, these dust cells or alveolar macrophages going around, Johnny on the spot, making sure that everything is picked up and everything that could possibly go wrong down there in the alveoli is taken care of by these guys. We also have alveolar pores. What are these for?
Connecting all of them?
Connecting alveoli. And why do we need them to connect?
Like an equalization of pressure.
Keeping the pressure equal among all the alveoli. Exactly right. Good. I think this is where we came to our conclusion, or I maybe buzzed right through this. This is the next thing to talk about, is how we get that gas to and fro. So here is the alveolus. Here's our capillary bed. Remember, there's capillaries over all the alveoli. And what we want to do is we want to move oxygen into the blood and move CO2 out of the blood. And this all occurs because we have a difference in pressures. So we have a high pressure of oxygen in the alveoli, high pressure of CO2 in the blood. Yeah.
Quick thing.
Yeah.
Alveolus is singular alveoli?
Correct.
Just one.
One alveolus, multiple alveoli.
Okay.
One bronchus, multiple bronchi.
Okay.
Yeah. All right, so between our alveolus and our capillary, we have a basement membrane. The epithelium of the alveolus, which is, of course, stratified squamous plasma membranes, And the endothelium of our capillary, along with the basement membrane, form a respiratory membrane. We're going to keep an eye on that because as we get to talking about our diffusion of these gases and how it all moves around, we're going to be talking about that respiratory membrane again. The beautiful thing about having so many alveoli is that we have increased surface area, and increased surface area means that we can move more gases more readily, especially when we need to. So right now, while you're sitting there, you're accessing a fraction of the lung tissue and the lung capacity that you have, which is readily apparent if you don't exercise and you go out and try and exercise and you're like huffing and puffing right away. But if you do exercise and you practice getting more air into your lungs and using more of your lung tissue, you don't get as huffy puffy as quickly, right? Yeah.
I actually have a question about that.
Yeah.
Are some people born to be like more huffy puffy because of, like, I know that your genes have something to do with it, but also can it just be like the way you are sometimes, you know?
Which would be genes.
Where you can, okay, it would still just be genes. There's not like certain illnesses that make it, besides
For
COPD
certain,
and
there are
stuff,
certain
like, you know,
illnesses.
like when you're younger is what I mean. Besides asthma and the regular stuff, something that you can be born with that causes that, or is it mainly just like the asthma and the COPD and stuff like that?
Well, I
it's a
don't
weird
know if there are
question.
any childhood conditions that are genetic, in terms of, you're talking anatomical.
I mean,
Are you talking
yeah.
anatomical?
Sorry, yeah.
I-
Like the difference in like lung size. Can somebody be like born with smaller lungs than usual?
Yes.
And
I
what
imagine that
happens in
always
that
is the case.
I would
situation?
bet.
But let's look it up. So Michaela, would you please write that down as a question? Yes, and you have a question.
Excavatum does that.
Hmm?
Practice excavatum does that. The bone structural tissue.
Oh, for sure, right, and you can have changes in your thorax and your, right, you can have a, what they call the bird keel thorax, so projecting out or projecting in, which would eliminate, that would be an anatomical.
That does make, okay.
Yeah, so it would eliminate the ability for your lung, not necessarily smaller lungs, but compression
That
that
does
would
make
eliminate
sense.
them.
Sorry, I didn't hear that question for.
Write it down.
But wouldn't it like effectively like give your lung away? Because oh, you know, it's tripping me. Never mind. I was like, wait.
All right, so, notice the low blood pressure in the lungs. And this low blood pressure is going to enhance lymphatic drainage and keep those fluids moving in the lungs, which we want to do. We don't want those fluids to build up in the lungs. I think we're already really clear on this, that we have multiple tissues in the respiratory system. You got cartilage. What kind of cartilage? And? Elastic. Where's the elastic? Yes, can't fool you on that. And we got smooth muscle, lots of smooth muscle all over the place. And we have lots of different epithelium, in fact. Right? One pseudostratified, stratified,
Keratinized.
singular, right? Keratinized. Yeah, we got squamous cells, everything. And then we have this lamina propria, which is just beneath the epithelium, and macrophages. We got tons of tissues, different tissues in this system. Really important to remember that the lungs not only are made of this simple squamous epithelium, but also there's some elastin tissue in there. And that elastin tissue, along with the bronchial tree, we need to have that elastin tissue because it enhances compliance. And compliance means the ability to bring air in and push air out again. When we lose that compliance, we lose the ability to get rid of that extra CO2. And we lose the ability to really bring in fresh oxygen. So compliance is a big deal in terms of ventilation. Next thing we're going to talk about is these pleural fluids and the pleural membranes. Do you remember them? What's the one that's lining the thoracic walls? Parietal. What's the word? Parietal what? Pleura. And then the one that's covering the surface of the lungs? Visceral pleura. And those two form what's called a virtual space. It's a space, it exists. However, that space is very, very small, and it is filled with fluid. What's the fluid? A serous fluid, right? Pleural fluid. And that is a water-based fluid. And what do we know about water? Water molecules. They attach to each other via
Oh, a hydrogen bond.
Hydrogen bonds, that's right. So water molecules form a cohesive connection to each other via hydrogen bonds. Water molecules also form adhesive connections to other surfaces. And so the fluid that is sitting between the lung and the thoracic wall is holding that lung to the thoracic wall. Yes. Very interesting. So I want to pay attention to some terms here. Intrapulmonary, within the lung. Intrapleural, outside the lung. And then your pleural cavity between the two. Now, we bring air in. There's only one way for that air to go. It is going to come down the trachea, and it's going to have to go into these two lungs. But what is it that brings that air in? That's the next mystery. That's the next piece to learn about. How do we move air in and out of our lungs? And now we're starting to talk about some physiology. Take a deep breath. And then, which one required energy?
Inhale.
Inspiration. Inspiration is an active process. Expiration is a passive process. It's a recoil of those muscles. When you breathe in, what muscles are you using to bring that air to breathe in?
Diaphragm and external intercostals.
External intercostals and diaphragm, exactly right. Which muscles do you use when you passively expire?
None.
None, right. Because it's just a recoil of those muscles relaxing. Okay. When we breathe, we are saying that we are conducting pulmonary ventilation. That's the term for breathing. Inhale, exhale, inspiration, expiration. It's called ventilation, pulmonary ventilation. Then we have a process known as external respiration. External respiration is involving the blood and the alveoli, and the movement of CO2 from the blood into the alveoli, and the movement of oxygen from the alveoli into the blood. That's it for external respiration. We then have this process of moving the gases around in the body, and what system are we depending on for that? Circulatory system, of course. We're moving our gases via the blood. And then we have internal respiration. Internal respiration is simply that oxygen being delivered to the tissues from the blood, and the CO2 being delivered from the tissues to the blood. Respiratory system, this system we're talking about now, is only responsible for that ventilation and the external respiration. All of this stuff is dependent on our circulatory system. Okay, so we have our air moving in and out. In and out, we call it breathing, pretty important, because if we don't get oxygen down into the alveoli, we can't get it into the blood, we can't get it to the tissues, can't get rid of CO2 from the blood into the alveoli, so it's important that we be able to breathe. Now, we are sitting basically here in Portland at an atmospheric pressure of about 760 millimeters of mercury, because we're close to sea level. I think we're at like 250 or 300 feet elevation in the valley.
Sounds cool.
And you gain a little bit, you don't get quite up to 2,000 in the ghost range, but then back down to the sea level. And atmospheric pressure is an important thing for us to remember, 760 millimeters of mercury. What it meant was that they had this big column of mercury, and they noticed that when they put it out there in the atmosphere, in the outside, the mercury got pushed all the way to 760 millimeters on the scale. That's how that worked. So we've stuck with that. So, and this is very important to remember, Mother Nature abhors a vacuum, and she does. She wants everything to be equal. And so she is going to try and move air that's at high pressure to low and low to high, so we can equalize the amount of pressure happening in atmosphere, but that's never going to happen. And that's how we get weather, believe it or not, changes in atmospheric pressure. So, but what we're going to do in our respiratory system is we are going to see changes between atmospheric pressure and the pressure within our lungs and within the pleural cavity. Okay, hang on with me. So inspiration, we already know, is an active process. And in inspiration, we are going to see our intrapulmonary pressure that is less than atmospheric pressure. intrapulmonary. Where's intrapulmonary? In the lungs. So it's going to have lower pressure in the lungs than in the atmosphere. Mother Nature doesn't like that. There's only one way that we can fix that. There's only one way that we can move that air in order to adjust the difference in pressure. So it's low here, it's higher outside. Air is going to rush down the trachea into the lungs to equalize the pressure. You will have equal pressure for a moment, and then you're going to change that pressure. And that pressure change is going to happen when you exhale. And you close down your thorax, you reduce the space, the volume, and you push that air, literally you push that air up and out of your trachea, nose, into the atmosphere. Normal inspiration, expiration is just a minor change in atmospheric pressure versus intrapulmonary pressure. So, and this happens, 12 to 15 times a minute. Every time you inspire, change in pressure, expiration, change in pressure. We have things that help us prevent total collapsing because of these changes in pressure. And one of those, of course, is our cranium and our skull, and that skull bones and the upper respiratory structures, like our sinuses. We have our cartilaginous rings in the trachea, and then those plates of cartilage along the lengths of your lobar and segmental bronchi. You have those fluids that are holding the lungs up and out. And so remember this, your lungs are constantly in a lower state of pressure than the atmosphere. So they are constantly partially inflated. And then you can inflate them more by increasing the volume in your thorax, which we're coming up to. We have that surfactant, right? The surfactant that's going to prevent them from collapsing and sticking to each other and allowing for easier diffusion of gases. So those things all help. There is a mechanics of respiration animation for you, if you got to check it out, just to reiterate the points that I've been bringing up here. And as I said earlier, poor Alice was trying to avoid being beat up by Mother Nature because Mother Nature abhors a vacuum. Okay, so what do we have over our control of atmospheric pressure? Well, we don't. We don't have any control over atmospheric pressure, but we do have some control over our lungs, thank goodness. Now, you are breathing without thinking about it now, the beautiful part about your medulla oblongata, but you can override the medulla oblongata and the pontine respiratory group and the pons, because you can hold your breath for a limited amount of time. And that depends on how much practice you have at holding your breath and how hard you work at changing that, right? All right, so we are going to change the volume in our thorax in order to affect the change that we need to bring air into our lungs. Right? Here's our thorax, inspiration versus thorax expiration. When we inspire, remember it's an active process, and we have nuclei in our medulla oblongata that tell us to do this. When we inspire, we lift the ribs up and out via the external intercostals, and we drop the diaphragm from its dome shape to a flattened structure. And by doing that, we increase the volume of our thorax both laterally and the anterior, posterior, inferior, superior aspects. So we increase the size of our thorax. What that does is it increases the volume. And we are now going to talk about Boyle's law. Mr. Boyle determined that pressure is inversely proportional to volume. When you increase the volume of space, you decrease the pressure that those gases have as they are bouncing around in that space. Boyle's law. Pressure is inversely proportional to volume. And this is going to help us bring air into our lungs. Because when we lift the ribs up and out and drop the diaphragm, we increase the volume in the thorax, then we increase the volume in our lungs. Mother Nature doesn't like the fact that we have lower pressure in the lungs than we do in the atmosphere, and air is going to rush in the only way it can go, down the trachea, down the primary bronchi, into the lobes, and into the segments of those lobes, and then the alveoli. That's simple. Then, when we breathe out, skeletal muscles relax. Ribs come down, diaphragm back up. What do we do to the volume? Decrease the volume. What do we do to the pressure? Increase the pressure. What's going to happen? Shove that air out, right? Squeeze it out. Simple inspiration, expiration is our nice, quiet exchange of gases. Inspiration, because we have increased the volume, decrease the pressure, air moves into the lungs. For a moment, we're going to be balanced, for a very brief moment. And then expiration. Expiration means diaphragm up, skeletal muscles, the intercostals down, we reduce the volume, we push air up and out. Simple as that. Normal, quiet respiration. Got to remember, though, that our lungs are always partially inflated. So they are always partially at the slight negative to atmospheric pressure. And remember this, the lungs are sticking to the pleural cavity because of that pleural fluid, holding them on constantly in a partial state of expansion, which we're going to talk about in a moment. Things can happen to that. Just 1 millimeter mercury difference on either side, so not a big deal, but significant, because we want those lungs to be partially inflated all the time. When they're not, we lose function of those lungs. You have a puncture from the outside to the lung, or from the inside where the rib punctures the lung. You can have atmospheric air enter, you lose that partial inflation, you lose the function of that lung. All right, so how do we manipulate thoracic cavity volume? Clearly, skeletal muscles. Increase, decrease, increase, decrease. Diaphragm flattens, you increase your volume of the thoracic cavity. What nerve is involved in that process? This harkens back to 231. No. Phrenic. C3, C4, C5, keep the diaphragm alive. Remember that one? C3, C4, C5, keep the diaphragm alive. You lose the phrenic on one side, you're good, you still got another on the other side, thank goodness you can still breathe. You lose both because you have a fracture of the cervical vertebrae. You could possibly not be able to breathe again. Christopher Reeve, Superman. Remember him? That gorgeous man. He was an equestrian. Did you know what happened to him? Yeah, he was an equestrian. He did combined eventing. So he was riding cross country on his horse. He was jumping a big fence. The horse stumbled, fell. He went off, broke his neck. Paralyzed, quadriplegic, respiratory machine, the rest of his life. And the rest of his life, of course, was devoted to researching stem cell repair of spinal cord injuries. So we need those muscles, we need those phrenic nerves in order to stimulate the diaphragm to contract. And that's all controlled, by the way, by the medulla oblongata and the pons, where we have nuclei responsible for inspiration, expiration, and increased inspiration, expiration, and responses to our emotional state, our physical state, right there in the pons. All right, so we know about the external intercostals, we know about the diaphragm, right? We got all of that. This is merely pointing to how we see pressure changes. So in inspiration, we see a change in pressure. What happens to the pressure when we inspire? Or what drives inspiration? A change in pressure? Decrease in pressure. And by pressure, we're talking about gases, right? And then we see an increase in pressure in expiration. Same thing for our intra-alveolar pressure, decrease in pressure in the alveoli. Great, so what is that going to do to our alveoli? Open them up, right? Yeah. So we have even better access to all that surface area. And then we see a decrease in pressure, or an increase in pressure overall for expiration. This is the flip. Here's the flip. Changes in volume. When we decrease the pressure, we see an increase in volume. When we increase the pressure, we see a decrease in volume. I feel like I'm beating a dead horse here. Everybody got that? Pretty easy concept to get, right? Okay, so that was nice, just quiet, normal ventilation. Nice, quiet ventilation. Inspiration, diaphragm contracts, skeletal external intercostals contract, expiration, passive process, pushing that air back out. We move approximately, or we have the room for approximately 500 ml of air. Yeah.
sorry, I had a question that popped in my head about a previous bit. When we're like singers and those who study like meditation and stuff, they do the breathe from the gut thing. So doesn't it affect not just like the diaphragm, but also the
Absolutely,
internals of
yeah.
your other organs?
Because you can compress those organs by compressing your abdominal musculature, and that impacts the volume in your thorax for sure, because you're pressing up on the diaphragm, so you can't increase your volume that much. Yeah.
So just had that thought.
Yeah, good thought. This is something called a model lung. There's a bell jar. This stopper right here has a hole in it that's representing the trachea. We have a diaphragm on the bottom. We have these two balloons that are representing lungs. And when I bring the diaphragm down, you're going to see what happens to the lungs. What happens to the lungs when I increase the volume? Yeah, and now I'm going to decrease the volume. What happens to our lungs? Yeah. We can build these in lab. We have bottles, balloons. You can build your own little model lung, take it home with you. You can do that week 3. All right. What else? Forced. So yeah, we can move approximately 500, so hold approximately 500 mil of air, normal, quiet, inspiration, expiration. We can move more air if we get into forced inspiration and expiration. Think of exercise. When we move more air through exercise, we obviously are going to increase our breathing rate. What is it that's going to drive that increase in respiration? CO2, exactly. You're exercising, you're making more of it. Your brain says, hey, pH is dropping, get going. Get rid of that CO2. When we do forced inspiration, we're going to involve some additional muscles. External intercostals and diaphragm are still involved. However, you're also going to use your sternocleidomastoid. What's that going to do? Exactly. You're going to use your pectoralis minor and major. What's the scalene's going to do? Same idea, lifting everything up and out. What's your erector spinae going to do?
Straight.
Straighten it back.
Absolutely, it's going to enable you to increase the size of your thorax. Because when you're like this, it's all compressed. You've compressed your abdomen up against the diaphragm. How about your serratus anterior? Same idea. So lifting things up and out. Exactly right. And expiration, we have a forced expiration too, because we're not just making more CO2, we also got to get rid of that additional CO2. And so we're going to use muscles like our internal intercostals and our rectus abdominis, and actually you can think of the other abdominal muscles as well. How's that going to work? What's that about?
Pull things back down.
Yeah. Well, this is an interesting little, I like this image a lot, because it shows you how the external intercostals are going to lift your ribs up and out. Because of this is the insertion for that muscle. This is the, this is the origin for that muscle. This is the insertion for that muscle. So you can see how the ribs get lifted up and out. The diaphragm first drops. I think everybody's got that clear. And then we see here our internal intercostals have a similar origin and insertion, but the insertion is on the lower boundary of the rib, which is going to pull those ribs closer together. And our pectoralis here, right, lifting things up and out. These are some of the serratus anterior muscles that are going to be closing things down. What else? That's it. Easy to understand, yeah? How we're going to use all those muscles to our advantage. Okay. We know this. Most breathing is quiet. Inhale, exhale. But sometimes we do see a change, and those changes are going to be dealt with via the nuclei that are managing our respiratory rate overall. And the nuclei are contained within the medulla oblongata and the pons, and they have different names, as you might imagine. Fortunately, most everything in the body is symmetrical, and so we have a relationship between the two pons, two sides of the pons, two sides of the medulla oblongata. We get everything's symmetrical. So here is our respiratory nuclei. We have a ventral respiratory group, And the ventral respiratory group, I don't know if you have seen this, but you might see some places where the dorsal respiratory group is identified as the primary quiet inspiration, expiration driver. We're sticking with lower. That's the one I have found more often referred to as the one that's responsible for quiet inspiration, expiration, the ventral respiratory group. Nice and rhythmic, quiet, inspire, inspiratory neurons fire. They fire for a little while, then they quit firing, and the expiratory neurons fire, and you inspire, and then you expire. You inspire and you expire. Seconds long inspiration, seconds long expiration. Quiet, nice and quiet. But sometimes you need to have a little bit more movement. And that movement might be dictated by changes in the pH of the cerebrospinal fluid. What would that do? You're walking. You've been sitting, now you're walking. Now you're going to see a little increase in your respiratory rate. And that's due to the dorsal respiratory group. Both of these are in the medulla. The dorsal respiratory group is also going to receive information not just from the central chemoreceptors in the medulla, but also this respiratory group called the pontine respiratory group. And then scattered throughout the body, you might remember this from 232, we have chemoreceptors that can pick up oxygen levels at the carotid artery, the sinuses and the bodies, right? The carotid sinus, carotid bodies. Changes in pH, changes in oxygen levels, CO2 levels. Stretch and irritant receptors are going to indicate that we need to change our respiratory rate because something has invaded, gotten into irritants down into the carina or down into the deeper recesses of your lungs. So you gotta get rid of that stuff, so you're gonna increase your respiratory rate due to that. This dorsal respiratory group, receiving information from the pontine respiratory group, is receiving it via a part of the pontine respiratory group called the apneustic center, and it is all about inspiration, so increasing the rate that you inspire. Obviously, if you increase the rate you inspire, you increase the rate that you expire, right? Simple enough for that. All right, so we have the ventral respiratory group, nice quiet inhalation, exhalation, inspiratory neurons fire, they quit firing, expiratory neurons fire, they quit firing, back and forth, back and forth. And we have the dorsal respiratory group that responds to increased need to move the gases. And we have the pontine respiratory group that is especially good at detecting things like your emotional responses. So when you cry, what happens to your breathing?
More erratic.
When you're really crying, you're like, right? Yeah. So it's the pontine respiratory group that is responding to that. And that leads to an increase in your respiratory rate. The apneustic part of this pontine respiratory group is going to stimulate the increase in your inhalations to deal with these changes in your emotional state or changes in your exercise routine, right? Changes in how much exercise you're getting at the moment. Changes in your sleep. Well, sleep is going to be quiet, even quieter than what you do normally as you're sitting there today.
Unless you have a nightmare.
Changes in talking.
Unless you have a nightmare.
Unless you have a nightmare. This is true, yeah, could happen, right? Could happen, or you're sleepwalking. Yeah, things like that happen. So talking, of course, my respiratory rate is elevated right now, as is my blood pressure, because I'm up here yapping away. So we want to remember that we have 3 nuclei, 2 in the medulla oblongata, responsible for quiet inhalation, exhalation, and also responding to the apneustic center in the pontine respiratory group, right? That is going to increase our respiratory rate. So dorsal respiratory group, increased respiratory rate in response to what the pontine respiratory group detects is going on. I think I just made that even clearer for myself. Hopefully that worked for you. What other things happen that respond that have influences on the respiratory centers? Well, Okay, so we have these central chemoreceptors in the medulla, and we already know about this CO2 plus H2O yields carbonic acid, yields bicarbonate and hydrogen ions, goes back and forth, back and forth. Those hydrogen ions in excess go into the blood, from the blood to the cerebrospinal fluid, changes the pH of the cerebrospinal fluid, medulla oblongata goes, you're too acidic. The reason for that is you have too much CO2, you gotta ventilate, gotta get rid of that extra CO2. And so that is what this pH of the cerebrospinal fluid is all about. And we know that we have those aortic bodies and the carotid bodies that I just was mentioning. And look at this, the glossopharyngeal nerves actually have something to do with those carotid bodies. What are carotid bodies? What are aortic bodies? Do you remember that?
Bodies are chemoreceptors, right?
Yes,
And sinuses are barrels.
yes. How did you remember that?
I just remember the sinuses, pressure.
Yeah, once you get sinuses,
Yeah.
you got pressure, and then the other is chemist.
Yeah.
Good, good, good. That's the way I do it, for sure. Did everybody understand that? Yes? Those of you? Because the sinuses are gonna detect changes in pressure. The carotid bodies, the aortic bodies are gonna detect changes in chemicals, CO2 and oxygen. And these glossopharyngeal nerves are gonna be carried to the dorsal respiratory group. We have voluntary control over our respiratory system. However, our cerebrum, right, the cortex of our cerebrum, we can say, I'm going to hold my breath for a moment, but again, how long can you hold your breath? I am limited about the ability to hold my breath. What is it that's driving my forced inspiration again? CO2, exactly, because that's going to be building up regardless of what else is happening in the body. CO2 is your driver for respiration. We also have other mechanisms that help us prevent damage to our respiratory system. As this says, we actually have a reflex called the Herring-Gruner reflex that prevents our lungs from overexpanding, kind of blowing up. So that's cool. Keep that in mind. Excessive stretch triggers the Herring-Gruner reflex, and that Herring-Gruner reflex is going to prevent you from inhalation. Too much inhalation is going to slow your inhalation rate or stop you from inhaling and allow you to exhale again.
What, you mean we can't become balloons like that?
Yeah, that's right.
One person
You can't
Harry
become
Potter?
balloons. You can develop something called a barrel chest, where your lungs never fully empty, and that's a result of emphysema. We got irritant receptors, all kinds of irritants in the air. Where are our irritant receptors located? Well, all over the upper respiratory system, right? Got irritant receptors in your nasal passages.
For sneezing.
Especially though we have a collection of them in the larynx, irritant receptors, and the carina. The carina where the two bifurcate off of the trachea. And they respond to all kinds of irritants, and some of us are more sensitive to pollen than others, and that's kind of a genetic thing and also.
Like allergies?
Yep, allergies. Yep. And those irritant receptors are going to result in, as you see here, apnea, which is no breathing, coughing, lots of coughing. You're going to have shallow breathing, and this bronchoconstriction, of course, is going to lead to that really shallow breathing because you can't get as much air in and out as you would normally. So irritant receptors are going to be signaling all of these things. And this little diagram is just a way for you to remember how all of these things are working along with your respiratory control centers in the medulla and the pons to drive your respiratory rate. Here you can hold your breath for a certain amount of time, voluntary control over your respiration. We have pain receptors, other things that can drive your respiratory rate as well. Hadn't even thought about the hypothalamus, but of course it's like the boss. You can increase or decrease your respiratory rate by stimuli like pain. You have the chemoreceptors. If your oxygen is down, your CO2 is up, your hydrogen ion concentration is up, you're going to see an increase in respiration. Which of those groups do you think is going to be responding to these chemoreceptors? The pontine and the pneumataxic and the and then the apneustic that's gonna drive the dorsal respiratory group to increase your, right? Yep. We got stretch receptors in the lungs. We're gonna see a decrease in our respiratory rate with stretch receptors because we're gonna slow that thing down, right? And then we're gonna see an increase or decrease in our respiratory rate with our irritant receptors because we wanna not drive that stuff down into the deeper recesses of our lungs. Now, how about this one? Receptors in our muscles and joints, increasing our respiratory rate. What's that about?
Like exercise?
Oxygen to ATP.
Exercise. You exercise, what are you producing? CO2. What's CO2 gonna do? Increase your respiratory rate. But here's the most amazing part of this. Like, you don't even have to get to that part of, you don't even have to get there before these signals are telling your medulla and pons that you are going to need to increase your respiratory rate. So this is actually, this prefaces what's happening in the medulla and the pons.
Gives that a little warning.
Isn't it? That's a little warning, like a little, guess what? You're gonna need to increase your respiratory rate. Yeah, cool. Okay, so I mentioned earlier how important compliance is. Well, compliance is the ability for your lungs to increase and decrease, increase and decrease. And that compliance is due to the elastin that is found within and around the circulatory system, the respiratory system, excuse me. Increase your compliance, you increase ventilation. Decrease compliance, decreases ventilation. You lose that elasticity, your lungs cannot rebound. You can't stretch them out, you can't rebound. So compliance is really important. And we see a loss of compliance, as this says, in conditions like emphysema, which is a fascinating condition. And you'll learn why in a moment. What if you don't make enough surfactant? Then you can have collapse, and you can have sticking of those alveoli. A loss of range of motion. Now, you probably wouldn't have thought of arthritis as impacting your respiratory system, would you? Why is arthritis going to impact your respiratory system?
It can stop your ribs from being able to bend, so they can't expand as well.
Yeah, you can get arthritis where the rib head articulates with the vertebra. And then you have pain when you breathe in. Yeah, I know, right? That's a problem. Yeah. Range of motion, spinal articulations, even your vertebrae, they have to be able to deal with that. Inhale, exhale. Definitely. This says barrel chests as a result of our decreased compliance. Barrel chests are developed when somebody has emphysema. And when somebody has emphysema, they are never able to get rid of all of the CO2 that is building up in their lungs. It's in the blood and it's delivered to the lungs, but they've lost compliance. And as well, they've lost alveoli. And they have bigger pockets that trap air, and it's called air trapping. And when you have these big pockets that trap the air, you can't get rid of it. And so you might have you ever met somebody with emphysema? What do they, how do they
It
breathe?
gives it like a whistly, raspy noise.
So you get a
almost.
raspy noise, but what else? Have you ever noticed them going?
Oh, extra breath, yeah, or like not extra breath, but like trying to catch their breath.
Yeah,
almost.
they're always trying to force that air out and they can't because they've lost compliance and they have these big pockets called air trapping pockets where CO2 just sits. What's CO2 do? Driving your respiratory. So if you've got a ton of it in the lungs, it means it's still in the blood because your diffusion, right, you don't have that pressure gradient, so the CO2 is not diffusing out of the blood. If it's not diffusing out of the blood, it's staying in the blood and it's causing more hydrogen ion gas. You can see how that can, right, carry on. Something else that can happen is that you can have this condition called atelectasis. I have to do that sometimes for myself so I can remember how to pronounce these things. Atelectasis is a partial or a complete collapsing of a lung. Now, one side, okay, you can deal with it, but not really, because you're really limited in how much you can move in one lung. This is usually the result of, as you say here, a pneumothorax. And a pneumothorax is when you penetrate that pleural cavity. What's that pleural cavity? That virtual space? between the lung and the thoracic wall, where your fluid is, that's holding the lung out. If you penetrate that, you have changed the negative pressure contained in the lung to atmospheric pressure. Lung collapses. Because we depend on that negative pressure in the lungs to maintain the partial inflation of the lungs at all times. So we want to keep that in mind. So a rupture of the alveoli can lead to this. You can have a broken rib, can lead to it. You can have puncture from the outside that can lead to it. Any of those can lead to a pneumothorax. They can fix a pneumothorax if it's minor. If there's multiple ribs fractured, they're going to wait for those ribs to repair before they try and reestablish that negative pressure. But they can remove that excess air by literally pulling it out. And they'll be pulling it in the plunger from the syringe that they're using is going to have back pressure until they've established that negative pressure within the lungs again. So they're pulling excess air out of that whole system. This is true. Oh, we're doing really good time. How's everybody doing? Got any questions? Is this making sense? Settling in a little bit? Yeah, good. So, as we've already mentioned, our normal quiet respiratory rate is between 12 and 15. Varies, of course, from person to person. But between 12 and 15 respirations per minute. We measure that volume of our respirations using a machine called a spirometer, or a piece of equipment called a spirometer. And did you watch the videos? The spirometer, the computerized ones, versus the little handheld job?
Yeah.
We have the little handheld jobs in lab, but really accurate spirometry is used as a computer and a very complex little setup to measure the amount of air that is moving in and out of the lungs at any given time. Some people with respiratory disease are going to have spirometry to determine what's happening in their lungs. How much air are they able to move? Yeah.
Can obesity affect the amount of air you can?
Absolutely.
Because you have potentially more weight.
Absolutely. Obesity, for a number of reasons. One, you're immobile. You don't tend to move much. So it's going to impact how deeply you breathe. It is also going to impact how much you can expand those muscles. Definitely. Yeah. All right, so we're going to be measuring volumes in our lungs now, talking about spirometry. Normal, quiet movement of air in and out of our lungs is referred to as tidal volume. Normal, quiet inspiration, movement in and out. Remember you said earlier that we move about 500 mil of air in normal, quiet inspiration, expiration. The reality is, however, that only, as this says, about 300, 350 mil is actually going to be accessible. And that's because we always have air in the trachea. We always have air in the nasal cavities. We always have air in the bronchi. But that's not involved at all in respiration. It's conducting spaces. It's not involved with respiration zone.
Yeah.
Right, moving of gases, yeah. So we have this mixing of air in the alveoli, in the lung, in the trachea, in the bronchi, and even in the alveoli. Because as we breathe air in, we take in fresh oxygen, but we're also then breathing air out, and we have CO2. We don't completely clean out those alveoli of oxygen before the next expiration. So we always have a little mixing of air here and there. However, important to remember that in the alveoli, we have a higher concentration of oxygen than we do in the blood and in the lungs. Oxygen diffuses down this concentration gradient from the alveoli to the lungs. In the lungs, we have a higher concentration of CO2 in the blood than we do in the alveoli. And so diffusion down this pressure gradient from the blood to the lungs of CO2. But we do have a mixing of air in those spaces. So we have tidal volume, normal, quiet, inspiration, expiration. We also have a thing called an expiratory reserve volume. So maybe you need to push more air out. You're exercising. Take more air in, you gotta push more air out. Expiratory reserve volume is that excessive forced air, forced expiration. Sometimes we need to take more air in, inspiratory reserve volume. That was forced air, inspiration. forced expiration. Expiratory reserve volume, forced expiration. Inspiratory reserve volume, forced inspiration. We have a residual volume down there in the recesses of the lungs. This is the air that's never accessed, the residual volume. And we also have what's known as vital capacity, where you combine your inspiratory reserve volume, your tidal volume, and your expiratory reserve volume, collectively known as vital capacity. Now, I'm not so concerned about these volumes, frankly, because they vary from individual to individual. I do want you to know what these are, the definitions of these are. And we're going to be looking at spirometry, and this is a graph of spirometry, and it's just merely pointing out the different types of volumes that we're measuring. Here's our tidal volume. In, out, in, out, in. Inspiratory reserve volume, significant. You can see over here, it's telling you what that is. This little panel is telling you what that is. This little panel is telling you what this is. And we have expiratory reserve volume here, and there's our panel telling you what that is. And when you combine the expiratory reserve volume, the tidal volume, the inspiratory reserve volume, we have vital capacity. Can you see the link there?
Mm-hmm.
Okay. We also have something called total capacity. Look at the total capacity. The total capacity includes both the inspiratory reserve volume, tidal volume, expiratory reserve, and also a functional residual capacity. So those people that are diving deep, they got the fins this long, they're sucking air in, they're really working at getting up to the deepest recesses of their lungs. They're working to get down into this residual volume. They're working to get as much of this functional residual capacity as possible. Because then they have the ability to hold their breath longer, because they got more oxygen in store. All right, so we want to remember tidal volume, inspiratory reserve, expiratory reserve, where they are on this graph, and what the combinations mean.
The formulas?
Yes.
Okay.
Mm-hmm. Yep. So tidal volume, I, R,
Oh, like
B.
abbreviations?
yeah,
Oh, okay.
yeah, yeah.
Oh, I was wondering, do we need to know the ERD plus TB plus IRD? And there was some other ones too, but mainly the one that, yeah.
Yep, this is vital capacity. Yes, definitely.
Okay.
Yep, definitely. Definitely. Now this video is available to you. It's really valuable. I think you should watch it. It shows you what a true spirometry test does. This individual has no respiratory condition whatsoever, but it is cool to see how she's equipped, right? They've closed off the nasal cavity, so she can only breathe through this instrument, which is connected to a computer, and the computer is going to give the guy the whole readout. And then this video, this is really good. I encourage you to watch this video 5 times. And I say 5 times because it's taken me 5 times to really pull it all together. It is amazing what can be determined when you look at your functional expiratory reserve volume versus your functional vital capacity. And this tells an individual whether or not they have emphysema or what kind of other respiratory condition they've got. It's really fascinating. Watch it, the guy explains it beautifully. It's cool. And then we have our tables talking about all of that stuff. And that's the end of lecture 2. And we're doing good. I definitely wanted to break into 3.